All right, so we're going to be talking about changes to family dynamics, which there are the basics about it. I'm going to explain what's going to happen in 3 different exemplars. There's an aging family, so changes in family dynamics, the extending family, and then the family with a disability. So we're going to go through all of this, and I promise I'm going to just glide you through, and it will be great. All right, so basically, it's really important to be aware of what a family, the definition of what things mean. So family dynamics is stated to say interrelationships among individual family members or the force at work within a family that produces particular behaviors or symptoms. All right, so that makes sense. And family is reciprocal relationships in which persons are committed to one another. So there could be many different kinds of families. So just be aware of that. So family dynamics could be positive, they could be negative, supportive, destructive, nurturing, damaging. So it's not necessarily a positive thing all the time. And the family, each developmental stage brings new demands. So I'll explain what the developmental stage of a family means, because everything in nursing has some developmental stage. All right, so the different kinds of structures of family is nuclear family. That's like my family. My family has a mother, father. I guess I don't have a brother, so I'm not like the typical, but I have 2 sisters. So that's like the nuclear family. The single parent family is like a person with just a mother or and a child. Unmarried, biological, or adoptive. Unmarried biological can be like the parents who didn't get married, but they're living together. A blending family is like the Brady Bunch. Cohabitating, just 2 random families together, I guess. And there's others. There are all different kinds of families. It's the basic concept of being committed to each other is the concept of what a family means. All right, so now I'm going to explain. There's influences that affect the family's coping. Just be aware of that. So now that we know the different kinds of families, we can explain what is the basic family cycle. So the basic family cycle basically is launching a young adult. So a launching young adult like me would be like going out of my family, and then I would get married, and then I would have family with young children, then I would have family with an adolescent, and then I had family as a launching center again, so it goes in a cycle. And then there's the aging families that are empty nest syndrome. Okay, so that makes sense. So families have different functions. So there's an emotional function, like does it provide love, a social function, management, who manages, like it's really important when you think of the elderly, who gives grandma medicine. So this is like functional. There's social, and boundaries can come in 3 different categories. There could be diffuse boundaries, they could be clear, they could be rigid and disengaged. So there's many different kinds of boundaries of families as well to be aware of. There's a lot of different things. Okay, so the family assessment that you want to do is there's family assessment. The family APGAR is the fastest one. It's a quick 5-minute questionnaire that may be used as the initial screening. So that's the first one you want to do. You always want to do the fastest one first, the screening. There's other assessment models, the Calgary. I'll explain what that is. It's a multidimensional framework with 3 major categories. The developmental, as we explained, are they launching? Are they adolescents? The structural, are they nuclear family? Are they cohabitating, all that stuff. And then the functional, who's giving grandma medications. That's just giving an example. And it expresses these aspects. So it is embedded in a larger worldview of postmodern feminism, biology, cognition. The theory is the foundation model includes systems like communication, changes, diversity issues. So it includes everything. So it's called the Calgary Family Assessment Model. And that's why we have to understand the structure of the family, the developmental of the family, and the function of the family. Okay, now we're just going to briefly explain that there's 4 approaches to family in the nursing. So like how as the nurse is going to react. So the family as a context is basically the individual comes first. So family is a constant. It's like they have a family, but the individual always comes first. The family is either considered a stressor or a resource. So it's family, it's patient first. So it's just basically based on perspective. The family as a system is considered an interacting system. So like the highways, like you think of their interactions, you're going to be aware of. The family as a client, this is when like the family process and relationships come first. So there's family as context, the patient comes first, and there's the family as a client where the the family as a client, the relationships come first. So family first. And then there's family as just a component of society, which is like seen as one of many institutions of society, along with the religion, the education, and the financial institutions. All right. So then family interventions for families would be like, there's a thing called a family triangle, and that's when basically there's two people who are like, maybe think of like two sisters who are just like, no, think of a mother and a daughter who's just at it, like they're just crazy. And one of the sisters, they're really close with the daughter, but they don't talk to the mom. You know what I mean? So like two people are mad at each other like that, and one person is really close with that girl, but then they don't talk to the other one at all. They have no relationship. So it's called the family triangle. Sometimes in therapy, they can do an identified patient, maybe only one person's the problem. There's insight-oriented family therapy to understand the origins of the problem so they can address the real problem. There's behavioral family therapy, psychoeducational family therapy. So behavioral is, I think, helping the whole family. Let's check. Family members identify undesirable behaviors, how they can unlearn these behaviors, learn desirable behaviors. So that's like the whole family. Psychoeducational is sharing the mental health information with others, so they allow their feelings to like vent out, teach about medication, reduce the symptoms. So this is really referring to the whole family care. All right, so now that we talked about that, we can talk about the aging family. So the aging family, we want to talk about, first, we're going to talk about the comprehensive assessment. Now let's talk about the clinical manifestations. So the aging family, they're going to be 65, it begins late adulthood. That's when like you're considered older. There's cognitive impairment. Cognitive impairment is actually not associated with normal aging, but is really becoming prevalent in our society, like Alzheimer's and delirium. So delirium is acute confusion, dementia, chronic confusion. So those are things to think about. There's depression screening for alcoholism because the patient may be really depressed. Many older adults will return to work. Healthcare expenses to provide socialization. They may have loneliness or boredom. If they're bored, they may be drinking lots of alcohol, so there's screening for that. Happiness is established. Happiness is often like very associated with established relationships. So if they don't have and maintain those relationships, they can experience depression. And there's also in Erickson, this would be the time frame where they have ego integrity versus despair. So do they look back on their lives and do they feel happy, or do they feel like they wasted their life, basically feeling? There's some comprehensive geriatric assessments to be mindful of. There's environmental factors, physical and mental health, functional, economic, social status. So let's look at the notes real quick. Environmental, it could be the living situation, community, society. The physical would be health, wellness, spirituality. The mini mental exam is really important, dementia. They might have delirium, depression assessments, feeling about self, feeling of self related to others, what coping mechanisms, skills, etc. of assessing loss, and is asking patient to speak about previous loss. So these are the physical and mental. So physical and mental is important to assess these patients. And also instrumental activities of daily living is really important, like family assessments, their intimate family relationships, past and present role changes, like are they bored, caregiving roles, financing, housing, social networks, activities. So basically we're going to be looking at those caregivers and how's the, is there any role, caregiver role strain? So it's not just the older parent, it's also, there's really two patients involved if you think about it. All right, so there are 3 different theories to be mindful of. There's activity theory. That's just that normal aging is better when healthy when they continue activity. It's continuation of activities performed in middle age as necessary for successful aging. Continuative theory is personality becomes more stable and behavior becomes more predictable as one ages, so continuity. So that I guess they're being more true to themselves, their true personality. Disengagement, individual withdraws from customary roles and begins more introspective, self-focused activities. These are only theories, so be mindful that every person's an individual. All right, so some complications to be mindful of for these older patients is caregivers are often abusers. Just be mindful of that. So make sure you take care of the caregiver's stress. It's not like on purpose, it's just like this very stressful. So like there's certain sayings to be like look out for. They may be denial, anger, social withdrawal, anxiety, depression, exhaustion, irritability, sleepiness, lack of concentration, health problems. So these are things to look out for. Let's look at like some of the sayings. I don't care anymore. That's like that's when they're really depressed. Or I don't care about getting together with any neighbors anymore. They're getting to social isolation. They're withdrawing. I'm too tired to do anything. This physical exhaustion. If he asks me one more time, I will scream. These are like anger. I know my mom is going to get better. This is denial. I cannot remember the last time I felt good. This is their health problems are coming from it because stress can cause health problems. All right, so some interventions to look at. It's really important to assess who makes the decisions of the family, who's the functional one who takes care of them. Other things to look for is educate the family caregiver to make sure that they get the medications on time. Hospice care, if that's needed, referred by the nurse from the patient who prefers to die. They may prefer to die at home. Just be mindful of hospice coming at the older age ones. Teach family about therapeutic communication, touch, make because the patient may feel isolated. Reality orientation for delirium and dementia. Provide. Facilitate mental health counseling. There's individual therapy and there's community-based therapy. So let's talk about this. There's the individual therapy is for cognitive, like behavioral, motivational, interpersonal, psychodynamic. But then the community ones are really important because they may be isolated, So psychotherapy is to elevate psychiatric symptoms, increase ability to interact with others, increase self-esteem, increase ability to make decisions and function more independently. Psychosocial is more associated with getting those patients to interact. Remotivation therapy is to re-socialize regressed and apathetic patients that are just like withdrawing, to reawaken their interest into the environment. The one I heard about a lot was Remanence Therapy, which is really associated with older adults because they get to share their memories of the past, and which will increase their self-esteem and increase the socialization with other patients, and it will increase their awareness of uniqueness compared to other patients. So it makes them feel like it raises their self-esteem. The goal for these older age is restore the interpersonal relationship and activities at the previous level or desired by the older adult. So that's the goal. Some nursing applications is, there's an acronym called TLC. TLC, as a reminder, T stands for training and care techniques, safe medication use, recognize abnormalities and available resources. L stands for leaving the care situation to obtain respite care, relaxation, obtain normal daily living functions. So that's really important. So getting that patient caregiver to just leave the situation a little bit and come back to it. C is for care for the caregiver through adequate sleep. So C, make sure that the caregiver is caring for themselves basically and not getting drained, because that makes them at risk for the caregiver abuse. And be aware of normal aging, drug interactions, and chronic use, chronic diseases. So that's the main thing for changes in family dynamics. Hold on. Because the next one we're going to do is, let's talk about the extending family members. So what are the assessments for the extending family member? Let's talk about what it is first. This could be a blending family, so it's basically introducing new family members. This doesn't have to be just having a baby, so it could be an adopted family member, a birth of a new baby, a blending family, like they're having randomly a new brother, the Brady Bunch. So those are things to think about. There's assessments that you want to really assess those risk and protective factors. There's genograms. Family cohesion, you want to see the family cohesion, dynamics, functions, the functions of family, strengths, and attachment behaviors. These are just things to watch for, not really interventions and stuff. Okay, so I think it's important to understand what are protective factors. A newborn protective factors would be like good health, parental would have good self-esteem, welcoming the baby, whereas negative would be, risk factors would be like not wanting the baby to come home or unplanned pregnancies. So, all right, so I even say it in extra notes, newborn risk factors and prenatal care risk factors. Perinatal baby, unplanned, unwanted at birth, newborn preterm birth, developmental delays. These cause stress on the family. Complications could be a new addition of sibling adaptation. They may not adapt so well. They may not want a brother. Grandparent adaptation. They may feel like they're not involved, so you want to get the nurse wants to get them to be involved, to teach that the grandparents can be involved. For adoption, bullying, multiracial may be a problem, so make sure they actually talk to the child. Blending step-parent, acceptance of siblings of older age, flexibility, mutual support, and open communication in therapeutic relationships is very important for this. Adoption for the bullying, multiracial. I'm gonna go backwards real quick. The adolescent may feel a feeling of abandonment when they realize they're adopted, but make sure you are very truthful and true and don't lie to them. It's really important because then they won't trust you as an adopted the parents who adopted them. For interventions for the nurse's role when a new baby is born, there's a thing called engrossment, which means that you're involving him in care. Involve the husband in care, not just the woman. Effacement is building that relationship, carrying the baby like that, and effacement, like creating that connection with the baby. Early contact for the newborns is highly advised. So that's everything for the expanded family. So the last one we're going to be talking about is disability of the family, of a family member. Let's talk about assessments first. You want to assess for the family's history, their structural of the family. The structure is a nuclear family, cohabitating, the developmental level, the function of the family. Those are always things you need to assess. Assess also the family cohesion. What are the family coping? So factors that include the coping can be internal and external. So factors influencing resources, service provision, social support, family cohesion, functioning, personality variables, maternal resources, internal and external. So internal could be just protective factors, Independent factors would be nature and degree of disability, gender roles, socioeconomic status, experience of stress and coping, stages of family life, ambiguity of diagnosis, delayed diagnosis, and expectations of child and adult. External source factors are really associated with having support from outside the family, whereas internal is more like their coping mechanisms. Family resiliency is a big thing. Do they have the ability, do they have those protective factors to cope? And how resilient are they, are important things. So you're going to want to get a history of relationship, personal and social, professional histories, impact of the illness or disability on the family. It's different for all family members. And family assessment questionnaire. So who has the most challenge, because everybody reacts differently, so that's really important. So maybe the caregiver, the mother, is really having a hard time. Some clinical manifestations you're going to see is protectiveness, grief, illness, financial burden. It may be really expensive for the family. They may feel like they have a lack of control, family relationship problems, a change in family roles, maybe isolation or anger, because just you can have very much anger. And caregiver role strain is also an issue with this. I'm going to talk about two things that are really important to assess and understand is the coping mechanisms of the family when it comes to disability, family member, and also resiliency. So coping to provide support. So providing skills, parent-to-parent support skills, individual, family, and marital counseling. Empowering the parents and the families as the nurse should help empower them. information provision, skills to care for the individual, local organizations, so external sources, advise to communicate openly and accept help from others, to seek out community resources and religious organizations. So teach the patients, families, that they can accept help from outside resources as well and not feel like ashamed for it. So resiliency, we're going to go, there's recovery factors, and then there's protective factors. Protective factors is what makes the family strong to be able to have recovery. Ongoing strengths would be like, examples would be like a birthday party, a holiday, think of Rosh Hashanah, Yom Kippur, Sukkot. Man, I have so many holidays. But it keeps the family strong to have those holidays, the reasons to have that family cohesiveness, and family time is really, really important so they can recover. So recovery factor is just saying beneficial in the actual event from an illness or loss of job. So it's beneficial when illness or a loss of job happens that they had these protective factors that helps them for the recovery. There's also another thing is development of resilience. And this is communication, seek professional help, develop a support system, learn respite, plan ahead, work together, and learn from experience. These are all factors that help the family develop resilience when the time comes and there are stressful events like illness and coping. So resilience is how fast can they bounce back up to their normal functional family. All right, so also when it comes to nurse-patient relationships, and like family therapy, since this is kind of related, it's really imperative that they focus is on the patient when it comes to just a nurse-patient relationship. And if it's individual therapy, there's an orientation phase, there's a work phase, and there's a termination phase when it comes to these therapeutic relationships. So the work phase is promote obtain a formal or informal contract. This is going to include, so for this informal contract, what are the physical, so basically, what are the confidentiality agreements? The contract is the time. What time? Be specific. Create those boundaries. So confidentiality agreement of the role between the patient and the nurse. So be aware of that. And personal space would be personal space, physical space. So keeping that confidentiality is really important. And also the physical. So the physical location is also really important. So the physical would be like location, like would it be Starbucks, would it be the office, would it be, so that's really, 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 really important. So the physical boundary was physical boundary, the contract, which was the time, and the personal space, the confidentiality, the personal space. So the physical boundary, the contract, and the personal space. So the physical boundary, office space, treatment room, conference room, the contract, the set time and confidentiality agreement of the role between the nurse and the patient, and the personal space was the physical space, the emotional space, and space set by the rules. So that's really important. And during the orientation phase, they obtain formal and informal contract. The work phase is when they promote problem solving. The termination phase is when they discuss ways to incorporate into the daily life and count the sessions that happened during that therapeutic relationship. The nurse-patient relationship requires patient to trust and active participation. So that's really important. So it requires both ends. Listening, balancing, control, and initial impression is extremely important. There's other things to note. All right, so we talked about that. It's also really important to know if the nurse is overly involved. The nurse is considered overly involved if there's more frequent requests for that nurse. Inability of the patient to perform tasks could be a sign. Unwillingness of the patient to maintain performance, expressions of anger by other staff, or nurses keeping secrets. These are signs of the nurse being overly involved. Be mindful of that. The nurse that is not involved is also an issue. Failure of the nurse to follow through on agreed upon interventions. There will be a lack of progress. The goals won't be met. They won't answer the call light. There's also Be mindful there's other terminology used like transference and countertransference. Transference is when the patient displaces onto the nurse the feeling or behavior of related fast figures like, oh, you remind me of your brother or sister, so they start treating you like a brother or sister. And countertransference is the nurse, the counter is more associated with the nurse's feelings and displaces patient's feelings and behaviors like, oh, the nurse starts treating the patient as if it's their brother or sister. So this is really important when it comes to relationships. So I'm just putting this on the extra. So countertransference, they can react in multiple ways: boredom, rescuing, over-involvement, over-identification, misuse of honesty, anger, helplessness, and hopelessness. Just be mindful that interpersonal relationships, with the concept we were discussing, which we were focusing on family relationships, but it's also really important that this can apply to nurse-patient relationship as well. It's more on a professional level. There's a person who discusses interpersonal relationships with the Papelal, and she introduced the concept of nurse-patient relationship. So giving credit to who created this. And she's the one who said the Papelal's interactive nurse-patient client process is designed to facilitate the client's boundaries management, independent problem-solving skills, and decision-making that promotes autonomy for that patient. And I just want to also say that there's a lot of screening tools out there. Just review them. Okay, so that is everything. Focus on those family dynamics for the disability patients, the extended family members, and also the aging patient. Be mindful that the caregivers may have a lot of role stress, and that you also have to take care of them as if they're the patient also. And that's everything, and so happy studying.